Let me do one more thing here. Make sure this stays. I want to make sure it stays up. Okay. You ready to share? Let's see how this works. We're going to see how this works. Can you see the screen? Okay. Okay. My video. Actually, I'm gonna leave it on for a minute, but then I'll turn it off. Okay. So there we go, and I should be full screen. Hey guys, good morning. I can see everyone's on, so thank you so much for hopping on. So this morning for our Zoom, there's a couple of basic things I want to cover and actually some fun stuff. So it shouldn't be like super long. We're not going to sit here for a half hour unless you force me to. So let's start with the basics. So we're going to do some little bit of updates. I got a case that I wanted to discuss with you guys because it was just freaky weird and interesting. And last but not least, we got to talk a little bit about COVID. So medical director updates from my seat. There's a couple of cool updates. So, well, some bad, some good. How about that? So the Sim House, we've shut it down for a little bit. And I believe the return date that it's going to start up again is November 14th or 16th, one of the two. Now, we have a bit of a rampage of COVID on the dispatch side. So for basically making sure that we all stay safe and things like that, we closed down the Sim House for a little bit, and that should help facilitate cleaning out some of the nastiness in our world and evening things out a little bit. And so that's your update for the Sim House. So those of you who haven't done the cardiac arrest, you're still going to get caught up in December. So that'll be, I believe, the first and second weeks of December where you'll get your nods. So don't worry, you're not going to miss out. The other big update that I have for you guys is the shift educators. So we had our first full meeting with the whole shift educator team, which I was super excited. We have an unbelievably engaging team. So that was like a 3-hour meeting where we are doing pretty rigorous training with the group, which has been exciting. We have a full retreat coming up later this month on, I believe, the 23rd of November, where I have them for the whole day. And all we talk about is education and how we're doing education and training them up as educators. So they're going to hear about adult learning. They're going to hear about mastery competency and why we care about that kind of stuff and how we interface with adult learners, things like that. So lots of rigorous training for the clinical shift educators. Super excited about this group, and it is moving forward. And I'm so pumped, to be honest. Not much gets me really excited, but this group is super engaged. And more than that, they are an awesome group that I think I'm probably going to overwhelm with all the stuff I'm going to teach them, but it's a good thing. So that's my big updates from my seat. So the thing I wanted to talk about first was a case. So this is an unbelievably weird case that I had literally last night. And so when it's real and it's just kind of on your mind, you kind of want to debrief. So I'm debriefing with you guys because this was wonky. So I was presented with a 27-year-old guy who fell down the stairs, and he was brought in by EMS. So this is someone that you guys would see on the field. The report was that he had about 6 beers and kind of slipped down the stairs, hit the back of his head, and came down. And he said that this happened maybe 4, 5, 6 hours ago. So it wasn't like right now. He was alert and oriented, but just kind of wonky. Like when I say wonky, he's kind of talking slow. He seems like he could be on marijuana or something like that, or, but he was a little diaphoretic. So he just didn't look right, but he looked more medical, not right. Like, so the diaphoresis, you're like, yeah, a drunk guy doesn't look diaphoretic. This is just, something is not adding up for this guy. Well, I mean, he fell and hit his head, and he did have beers. So let's take the obvious to be the obvious. And of course, we started out, and I got this guy on checkout from one of my partners. So he did the initial evaluation for the guy. And the initial evaluation he said is, hey, let's treat this guy like trauma. Let's consult trauma, and let's get this evaluated. And maybe his weirdness of mental status is all post-concussive. And that happens. We have to sometimes admit some of these trauma people because they're so post-concussed that they have like moderate to severe case of concussion. or closed head injury. And so then they have to actually get rehab and see PTOT and all that kind of stuff. Well, what ends up happening with this guy is we get to CT head, it's completely stone cold negative. We get a CT spine, that's negative. The lac on the back of his head that we finally found got fixed up, but he still was all gorked out. We really didn't have an idea. And then one of my techs, and I'm very proud of this tech because this tech is a paramedic, a new paramedic, who came and grabbed me and said, "Hey doc, something's weird." And this is not the exact EKG, but this was very similar. So in the chat, feel free to toss out some of your ideas of what you're seeing on this screen. So I'm going to give you guys a minute to tell me what you think this EKG is telling you. I love the chat.
Some of the P waves are different in lead 1, 2, and some are kind of peaked and some are smaller. And
yep, they're funkified. A hyper K from Scott. Any other thoughts, guys? Hypertrophic, yeah. That's a really good differential because like you got to think about the hypertrophic just because of how big your QRS complexes are. Cocaine, I thought so too. I'm like, did this guy just load up? Other thoughts? Come on, that's only 3 people. The waves. I can't spell, I'm sorry. I tossed your weird P waves in there.
Borderline first degree.
Nice, I like it. Works. Intracranial, okay, I like that. ICP, I like that, Keith. That's real good thinking. Cardiac tamponade, that's a good thought. Like, I love building this differential is good. So when you look at this EKG, one of the things which really struck me, and this is why I think it's a great teaching point for us because it just pulls things in, is when you look at V4, 5, and 6, you see this unbelievable T wave, which Scott Gano knocked out of the park as our instructor. I'm not surprised. Is the fact that you have this really peaky peak T wave. So if you see a T wave like that, and if you think to yourself, if I sit on that, I'm going to be impaled, then you probably should be starting to think about really some real badness. So in this case, what we started initially thinking of was, is this hyperkalemia? So this is one of the early signs of really bad hyperkalemia where you're seeing the peaking of T's. Oftentimes you'll see it throughout the EKG. In this case, you're seeing it more on V4, 5, and 6. We're not seeing any other signs yet, but I like the fact that you guys are already talking about what's happening with my big P wave here and my small P wave here. There's some funky stuff going on with this EKG, and that's not what you want to see. So keep in mind your findings for hyperkalemia are peak T waves. You can have an increased PR interval. So this goes back to that first degree we were just talking about. And then you have increased QRS width over time. So then you start widening out, and this is how you get blocks, and eventually you'll get a sine wave and it's asystole. So all good findings, important findings. So what did we get? So here's our chemistry. The guy had a creatinine of 4.5. His potassium was 7. Again, he's 27 years old. He's not my 65-year-old diabetic who can tolerate a potassium of 7, right? And he has a lactate of 3.2. This dude did something to himself, right? This is not a trauma patient unless he was laying there for 15 hours, right? So if he was laying on the ground for 15 hours and this happens, why do you guys think this happened? What would be the cause? So this is what we worry about for all our people who are just laying on the ground and won't get up and all that kind of fun stuff. And rhabdo is the word that was tossed out. And I'm gonna give a little bit of spelling corrected. Rhabdo. There we go, rhabdo. Yeah, rhabdomyolysis. So this guy could have fallen and broke everything down, and could have like been sitting there just getting toasted with his beer the night before, and now is falling completely apart. Uh, so that's a possibility. Brando is what you need. Nice. So is K of 7 lethal? We're pretty darn close to being lethal. Yeah, so he's up there and he's having some real issues. So the real question now is, what's the next step with this guy? And so we started working him up for the rhabdomyolysis. So we got a CK to look for muscle breakdown. I actually sat down and talked to the guy, and he was a big built guy. And I'm like, are you going crazy with your workouts? And he's like, oh yeah. Yesterday I just went off and blah, 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 blah. And by the way, he did use cocaine before his workout, because cocaine's a great stimulant to help you work out better. He informed me of that. So that was an educational point for me. I love that. So he did his cocaine and then did a ridiculous workout, and that's where he got himself. And so just to kind of touch base a little bit more on the potassium, we know higher potassium levels will cause EKG changes. Our normal is this nice QRS complex with a nice little T wave and a P wave before that. As we start going, we see that peaking of the T's. What I want you to think about peak T's is 3/4 of your QRS complex. So if you have a T which is 3/4 of the QRS complex, you should start thinking about peak T's. And then after that, you have the widening out. It's basically pull the two sides of the EKG and spread them out. You'll have a PR interval increase as well as QRS complex increase, eventually going to your sine wave. So this guy, so when we saw that EKG from my brand new paramedic who brought it to me, I'm like, holy crap. And so then we ran to the room, and he's just chilling in there being his altered self. But then we put the 12 lead on him, and once we got the 12 lead on him again, he definitely was peaked. He was peaked throughout, and he was starting to widen out. We hit him with calcium first, but of course he was getting a line at the time, so he was just getting his line in place. So we hit him with calcium. We gave him some we gave him some albuterol because he was young and healthy, and so we gave him albuterol. Not a common treatment, but something we have in our arsenal is to give somebody albuterol. It works really, really quickly, and it does actually shove that acidosis inside. And because we thought rhabdo and not rhabdo, we gave him bicarb. Because of course, if he has rhabdomyolysis, the treatment we're going to do for rhabdomyolysis is alkalinizing the urine. We're going to toss a bunch of bicarb in his fluids, and we're going to alkalinize his urine so it pulls it out of the kidney. And so just like we would do for crush injuries, giving bicarb fluids. And so we did that same thing in a different line. So we, in this case, because he was so acute, we gave bicarb pushes, so we did not use a different line. We only had one line with this guy because, well, that's just the way the fun works for a guy like this. We did not do glucagon, insulin, or glucose because we were hitting him also simultaneously with 2 liters of fluid once I got that line going. So I pressure bagged a bunch of fluid in for the guy. Interestingly enough, we then actually ordered something that's a little weird, which I wanted to bring up, is we ordered osmolality. So now this goes into the weird medicine crap. So when you are actually thinking that people aren't as trustworthy as you think they are, you can actually look at the gap in people's osmolality, okay? And the gap in osmolality will direct you to think about other types of alcohols, volatile alcohols. So things like ethylene glycol, methanol, things like that. So the bad things that people drink that they shouldn't be drinking, yet lead you to renal failure and stuff like that. It came back as positive for methanol. I haven't seen wood grain alcohol in like ever. So it came back with this guy drinking some wood grain alcohol at some point. I don't know how he did it. He does have rhabdo. So I'm not sure it's the chicken or the egg or what was the source of this, but he definitely has methanol in his blood. So we don't know if it was methanol which caused it, but we gave him fomepizole, which is the reversal agent. We used to give alcohol as a competitive antagonist. So Pabst Blue Ribbon is still on the formulary at Ohio State, by the way. That is Ohio State's beer of choice for the medical center, Pabst Blue Ribbon. And so that is, so we did not do that because we used the other antidote. But crazy, weird, awesomely unusual case that I just wanted to share with you guys. And so that's where we're at with that. Job security, you can't cure stupid. Thank you, Scott Gatto. I appreciate that. So any questions on this really weird case? Because I have a lot. Any thoughts, questions?
Dr. Panchal, was his mentation okay throughout, or did he go in and out of consciousness?
No, he was conscious. He was just really lethargic and just wonky. And it was like just, and now in hindsight, it was metabolic, right? These are those metabolic encephalopathics, which are just not acting right. They're not totally unconscious. They're barely responsive. Or in his case, we didn't have to sternal rub. I could just walk in there and yell at him. He'd wake up. But yeah, he never went unconscious on me, which is good. But the trauma was completely like, that was the red herring. That didn't help me. Cool. Well, thanks guys for putting up with my debrief. So the last thing I wanted to talk about, and everyone's favorite topic, COVID. I swear, for me, this is worse than the election map. It honestly is, because the election will eventually go away. This just will not go away, and it's driving me nuts at this point. So just to keep touching base like we have been, and actually when we're done with all this, I'm going to put all these things in a little slide so we can see the whole progression of all our pain. So going back to my Bing tracker that I've been using from the beginning, just because I like the images, we are still in this strong upswing. This is for all of the United States, so huge upswing right now, bigger than our other peaks, and we're getting a lot of positives right now, so it's really unfortunate for us. The other thing that I want to point out is that as we start looking at fatalities, we are seeing a bump in fatalities. And we're seeing this in the emergency department also, where our ICUs are filling up. We're putting in surge plans for possible surges in the ICU, and we have a lot more residents and physicians getting infected at this point, just because of the amount of contacts we're having. And it's not so much hospital contacts, it's community contacts which are getting us. But we are seeing an uptick again of fatalities. Now, keep in mind, fatalities are always going to be running behind the total, right? It's going to be running behind almost 2 weeks, 2 to 2.5 weeks from your initial infected cases. And so we are seeing that uptick. So just be really wary and be watchful of the people around you. And so when we look at Ohio, I mean, this is worse than where we've been before. I mean, this is pretty high end, really quick, really spiked, which is bringing a lot of attention. Now, again, our fatalities have not bumped up. So this is Ohio data on fatalities. That has not bumped up, which is good to see. But the supposition is, with a peak like this, I'm hoping people will come in and get care a lot quicker than they did early on, so that we aren't going to have a huge bump in fatalities. But I would warn you to look for these really acutely ill people. The biggest warning for our group, I think, more than anything else, is any patient you see of any type which has any complaint of congestion and things like that, be prepared. Definitely protect yourselves. I think more than anything else, I think that's going to be one of the biggest things that we have to watch for. And the other big thing we have to watch for is household contacts. If in any way, shape, or form anyone in your family is even a little bit ill, please just contact us and take the day. We'll figure out staffing, but I want to make sure that you guys stay safe. And more than that, you keep the rest of your station safe. I think that'll be really critical for us as we're going through December and into January, especially with people coming through with the holidays. So be very, I guess the word should be a little bit picky about those things. A great question from MedicFi. Are the numbers of COVID deaths reported presumed positive, or are they actually tested and have a positive result? Great question. They are actually, my understanding of most of the fatality data that's out there, are actually individuals at this point which are positive. So because we have enough testing now that we're able to test people to see they're positive. So that is one of those things that early on people were questioning what the data looks like. Now, no, you're welcome. Now at this point, I trust those fatalities to be real fatalities. And of course, it's one of those challenges that are progressive. Now, one good news, guys. So I do have a silver lining to this. A large study was done in Seattle looking at cardiac arrest events And they basically swabbed every single cardiac arrest, even if they were at the morgue, no matter what, they swabbed them for a period of 3 to 4 months through the peak, the early peak that we had. During that early peak, when they swabbed these people with cardiac arrest for COVID, what they found is the prevalence of COVID in that population and the cause of COVID for that cardiac arrest was very low. So what I mean, more like 2 to 3% of the total population had COVID. So the vast majority of cardiac arrest that we face based off that data is pretty low. Now, flip side of this, in Italy, in the big peak, when they had like almost 15 to 20% of people who were infected, so the prevalence was unbelievably high, the COVID positivity in that population was like 12 to 13%. And so that obviously we're not nearly at the stage where Italy was with their positivity. So we recognize, of course, that so much of the positivity for COVID in our population is going to definitely be due to prevalence, but that's definitely impacted our cardiac arrest events even more so. So that is some good things to feel a little more safe. But again, for any event, any shortness of breath, any cardiac arrest, any acute patient that you see, even altered mental status, gown up, protect yourself, be prepared for the badness overall. Cool. So guys, that is what I wanted to
Dr. Osh.
Go ahead, please. Yes, Jude.
Are they testing for the flu virus this year? Because the rumor going around is they're not testing for the flu virus this year.
Yeah, we're testing for flu.
Okay. No.
The problem is flu actually is run on the same machine as COVID. Okay, so the question ends up being, what do you want more? Do you want those COVID answers or do you need the flu answer, right? And so a lot of people, a lot of physicians specifically are choosing to order the COVID, and they'll say, hey, I don't really need the flu on this patient. Let me just get the COVID. If the COVID's negative, I'm just going to send this guy home. And that's not unreasonable. Sometimes what people are doing, especially in the ICU setting, is that they'll get or in the acutely ill setting in the emergency department, we'll get the COVID. If the COVID's negative, we'll get the flu.
Gotcha.
But that screening flu that we did every year, like when people just came in and we got the flu, it's not like that. So you're right, Jude. That is a big change in practice. A lot of people are expecting to come in the emergency department, get a flu test. A lot of people aren't doing that. They're just getting the COVIDs.
And one more question. What's the infection rate if we're testing, let's say, because we're testing more than ever, what's the infection rate per test? Do you know what I mean? And what's the false negative or the false positive? Do we have those numbers yet?
Yeah, we have it. We have a good idea. So it totally depends on the test, right? So if you look at your rapid test, so the rapid test, and this is an issue with how people are using it. So at OSU, when we do the rapid test, we only do the rapid on patients who have positive symptoms, either having a fever, shortness of breath, cough, things like that. So people who you think are probably COVID, that's the person you should do the rapid test on. And the rapid will come back in 10, 15 minutes, something like that. But the sensitivity and specificity isn't the best. It's like 70, 80%. And the reason being is if you use it on patients who are kind of borderline, it's not going to come back positive because you need high viral load for that test to be positive. So that's the rapid. If you do the PCR, now the PCR is what we'll do for most of all of our team and our employees. Anyone will do the PCR. The PCR takes days to come back. 12 for first responders at OSU, we're turning them around in 12 to 24 hours. And those PCRs, the sensitivity and specificity is really high. So that's good news. So we're looking up in the high 80s, 90s. So with that test, my expectation is that it's going to tell me it's COVID. Now, the only people that I'm going to doubt that result for is going to be the patients who are in the ICU and things like that. Now, the COVID test that we do for PCR and for rapid is all dependent on one thing, the quality of the sample, which is why nasopharyngeal swabs, when they're tickling your brain, sadly, that's the best sample, and you will get a good sample if you do it long enough. And so that should be the one that people are more apt to get and more apt to do rather than the oral. If you do the oral, your sensitivity and specificity goes down. If somebody's doing the saliva sample, that's a mixed bag in general, and that's still getting CLIA approved right now. So we are doing saliva batch testing on OSU students right now, but that's the only group that we'll do saliva testing on.
One more question. What about antigen testing? Like, So why don't we start at ground zero and test everybody, like from our department, so we know who's had it and who hasn't had it?
Because we don't know what it means. So the antigen testing, which is there right now, will just say that you've been exposed in some way, shape, or form, right? It doesn't, and the problem is there's cross reactivity of those antigens to common coronavirus, otherwise known as the common cold.
Mm.
So the grant that we've submitted is actually, and the one we were funded for that we're getting ready to do right now, is specifically to look at all these different seroconversions so we can identify what antibody testing matters. And if those antibody testings have any association with the level of infectivity, how you will pass it. So if you're an asymptomatic, will you pass it or not? Or if it affects any type of survival. And so the list of different antibodies that we're testing is a laundry list. The one that's being done right now is really generic, and it's not really, it just gives us a general concept, and it has cross reactivity. So my faith and trust in that one is really low. It doesn't really tell me much, which is also why we haven't gone down that road, because if we took all that testing energy and moved it to there, we probably wouldn't get enough COVID testing done.
Thank you.
No, great questions. These are awesome, awesome questions. And actually, Jude, to be honest with you, these are pretty high-end questions because these are all the questions we're asking on our grant.
Hey, Dr. Ash, I got to get your opinion on, I know 4 people personally that all of them have had multiple tests done. 2 of them, all of these were all asymptomatic people. Each of them had multiple tests done. 2 of them, the second test came back negative, and 2 other ones came back, all the tests were positive. 2 of them had three different tests done, and all of them positive. They were all asymptomatic, never got sick. I mean, I know that's making our numbers go up. Now, the problem is with the health department in Knox County, when they get the negative test, they don't send that back to the health department. So the only way the health department even knows if it's negative if you tell them personally.
Yeah, if you're picking up the phone.
So, you know, there you go with these positive numbers, and how many are even sick from it? I mean, you know, they're talking about the death rate might come up. It's not come up bad, but to me, is it overinflated? I mean, is it how accurate is this of saying that everyone's going to get sick if you get it? Because I'm seeing a lot of people that are positive that are not even sick.
Yeah, so I love your question. So, and I think a lot of this also is confabulated in the media. So there is a population, there's really a number of populations that we're looking at with this infectious process. We have our people who are sick and really sick, right? We have our people who are sick and kind of sick. We have our people who are asymptomatic but infected, and then we have people who are well. There are people who aren't getting infected. And so it is interesting that people are getting exposed and not infected at all. So those are kind of the 4 big batches that you have, okay? The ones that actually give us the most problem from a public health standpoint is that individual who's infected and asymptomatic. They are the biggest issue in this whole big mess of things. And the reason being is that's the individual who will carry it to your high-risk populations. With any pandemic, you assume and you expect that the patients who are at highest risk in your population, the elderly, the people with comorbidities, and for every pandemic, the disease process works a little different, but you expect a certain population to be at higher risk than everybody else. Those are the ones who are getting infected, dying, and doing badly. The asymptomatics are the ones who are carrying it to them. And this is why it was so bad at the beginning of the whole situation, because we didn't recognize the amount of power that these asymptomatics had. So the classic example was the nursing homes in Seattle. The disease was carried into the nursing homes by asymptomatic employees. And so they're the ones who carried it in, and then they infected these older individuals who then got the infection, did horribly, and died, right? So in the end, understanding the number of people who are overall infected, may they be asymptomatic or symptomatic, gives you an idea of the prevalence and the spread of the disease process. That's really important. That'll give you a lot of idea of what's going on. Those are real numbers. Then the other number, which gives you a lot of guidance of the disease process and the prevalence and the insidiousness of the disease process, is your fatalities. So seeing our fatalities go up gives you a real guidance about the severity of the disease process, right? So those two things are the ones that you should look at and think about. Now, the per capita number of people who are well versus sick. So that is a weird number to look at. And the reason I say that's a weird number to look at is because of the prevalence of these asymptomatic people doesn't really give you a good feeling inside, because the higher your asymptomatic population is, the harder it is for you to control the pandemic, right? So if we just look at all just raw numbers and say to ourselves, the asymptomatic people aren't getting sick, it doesn't really, it's not really telling the full story, right? And the full story really comes about when you look at your vast number of people who are getting infected, because that'll tell you the true prevalence of the disease. And then you look at your fatalities, and that just simplifies it overall, and that makes it a little cleaner for us to look at that data and understand better. Jude, great question. Kids and infection rates. So the kids, I love our little kitties, but as they are beautiful immune systems, they are getting infected. They are actually getting infected at high rates. So there's a couple of different studies which have shown that these kids are just getting infected just like everybody else. There is a good proportion of them who are getting so infected and getting ill enough to die. So we are seeing fatality rates as the overall prevalence of the disease process is going up and up throughout our community. So in the end, sadly, as we have not been able to get a really good hold on it, we're seeing more fatalities in children than we saw at the beginning, because again, the prevalence is getting higher and higher. So there's still—
Is that lesser in this pandemic though? Because it seems like, I've been reading back to past pandemics, it affects the elderly population and the young population the same. This one seems to be different because the death rate for kids seemed to be like almost non-existent to other pandemics. Am I wrong on that?
Well, so the other thing is you got to take in consideration the extent and the abilities that we have in medicine now, which changes the whole game. So,
Gotcha.
so our intensive care units and the abilities that we have, like doing ECMO, we put a lot of kids on ECMO nowadays. Like if a kid's looking bad, they're going on ECMO, right? And so the ability and bandwidth that we have to help these kids is so much more than back in the day where like they would just die and it was really sad, right? And another thing is, of course, our nutrition and all that kind of stuff also coats, like the general overall health in the United States in general coats a lot of that, which is really nice for us. So really hard to compare back though, Jude. That's a really good question. No, guys, this is tough. It's tough to piece out, and there's no good real answers. I think the biggest thing we just have to be really aware and be cautious about masking and keeping yourself safe, keeping your family safe, and keeping everyone around you safe. The holiday season is going to be tough on all of us. Well, that's all I have for you guys today. Thank you so much. Thanks for dealing with my debrief and all that. I'll keep giving you guys updates on how we're doing with our education processes and all that kind of stuff. We'll get the sim house going here soon. And that's all for me. Thank you guys. You guys all be safe out there and take care. Bye.
Bye.